friends, thank you for coming to this session on service delivery integration. In this room, we face three problems that I think you all can solve today, if you want to. The three problems are: one, the room is very big. Two, it's very cold. You saw it coming. And three, you just had lunch. So maybe your energy is a little down. So I offer you a solution if you would like. You could stand up. Everybody, stand up. Come on, come on, come on. Let's go. Up, up, up. And then if you move together and you huddle close together, you can stay warm. So if you come in, get closer, snuggle up, find a shoulder if you need to rest your head after lunch. Let's bring it in. We're a family. This is all good. Get close. Don't be shy. Thank you very much. Yeah, I hope that's better. So in this session on service delivery integration, we're going to look at a couple of key questions. So what are the major barriers to service delivery that caregivers cite, and how can they be addressed? Can service delivery integration for vaccination amplify birth dose coverage, and what challenges might impede the integration? And then how can they be surmounted? One of our presenters is currently in transit, so isn't here to present, has recorded a presentation, and we're working over here on the side to get that ready. So hopefully it's ready to go. We'll keep our fingers crossed. Dr. Salisu Sulaiman from the Clinton Health Access Initiative has recorded that. But luckily, in person, in 3 dimensions, we have Dr. Yaba Saidu, and it's an honor to have him here. Very highly accomplished professional in the field of global health with a background as a physician and a PhD in life sciences. Dr. Saidu currently holds the roles of country representative for the Clinton Health Access Initiative for Cameroon and is Africa editor for the Global Health Press. I have to read this, it's very long. Very impressive person. He's also a recognized leader in clinical trials and regulatory submissions, having partnered with both private and public sector agencies such as Novartis, Gavi, the Global Fund, USAID. Dr. Saidu has authored numerous publications and book chapters. And in addition, his exceptional service to the state of Cameroon has earned him a knighthood bestowed by the president. So do I refer to you as Sir Dr. Saidu?
Monsieur le Chevalier.
Yeah, Knight of the Long Table. That's very impressive. I think what we should do is start with your presentation, I believe. Yep. Okay. Push that. If you want to stay here, you can.
No, you want to just stand. I have just 4 minutes and 2 seconds to go through my presentation. No, actually 10 minutes. Okay, great. Now I'm a little bit confused because I don't know where to start. This is Salisu. Say that again? Is it okay? Okay, great. So I think looking at the hall, one can essentially say that getting a birth dose of hepatitis B within 24 hours of birth can be much more easier than getting a visa to travel to Panama, particularly if you come from Africa. And that is one of the reasons why Salisu and also my colleague Dr. Nnang could not actually make it to this conference. So now I cannot see, but we all know the importance of in short, the public health burden of infections caused by the hepatitis B virus. And in Cameroon happens to have like one of the highest prevalence of hepatitis B infections in Africa. I think currently the prevalence is about 11%, which is about I think 10 three percent point higher than the regional average for Africa. Because in Africa, I think it should be somewhere around 8%. And then the prevalence also amongst pregnant women in Cameroon is also high, greater than 8%. And because of this, the government has actually identified the importance of controlling these infectious diseases, which fortunately is preventable. And the government has taken a number of important steps to get this done. And importantly, this decision from the government was actually driven by occasions like this. The former Minister of Health took part in one of the hepatitis global conference in Dakar sometime in I think it should be in 2014 or so. And they talked about the importance of the bed dose of hepatitis B. And when he learned that this vaccine is very, very cheap, he decided to introduce it, and he actually allocated funds for the procurement of the vaccine itself. But the challenge is the vaccine. The challenge is actually the system to deliver the vaccine within within the first 24 hours of birth, and that is really one of the reasons why we embarked on this journey, trying to study the system and then propose a model that the government can use to effectively deliver this vaccine to children within the first 24 hours of birth in an equitable manner, including targeting children born both within the facility as well as children born outside of the facility. Because in Cameroon, the prevalence of out-of-facility birth is very, very high. In some regions, it can reach up to about 40%. So we had this as an overall objective. My eyes are very bad, so let me I can stand here. So we had an overall objective of assessing the feasibility of immunizing newborns, particularly with BCG and oral polio vaccine within 24 hours of birth by integrating routine immunization into maternity and immediate newborn care. And the reason why we actually conducted this study was really to understand the different factors, barriers and enablers that could affect that could affect a successful rollout of hepatitis B in Cameroon. And this is kind of important because many countries that have introduced the vaccine, the bed dose, I think they are still struggling with coverage. A country like Nigeria did introduce, and I think today they are less than, in short, the overall coverage is even less than 10%. So the specific objectives actually were threefold. The first was to integrate the bed dose immunization into maternity and immediate newborn services. Second was to measure the change in proportion of newborns receiving BCG and OPV within the first 24 hours of birth, and then assess the operational feasibility and acceptability of interventions and describe any enabling or impeding factors that may influence further implementation of the bed dose. So those were like the three overarching specific objectives that we had. And to accomplish these specific objectives, we designed this pilot. We designed this pilot, which was like a 12-week pilot in a section of health facilities in distinct geographical settings in Cameroon. And the interventions actually consisted of a number of things. The first was building the capacity of the frontline immunization staff. That's basically all the people who will be involved in the delivery of the vaccine, at least people who will be involved in forecasting, managing the cold chain, transporting the vaccine from the API services to the maternity and so on. And then the second thing was to develop some sort of a tailored schedule for administering this vaccine and ensuring that the storage points are accessible to maternity staff, and then outlining the roles and responsibilities of each healthcare worker involved, particularly at the level of the maternity, and then train them and develop and institute data collection tools that will complement existing existing tools that exist in the facility, particularly maternity registers and API tools. So we had a number of interesting findings, as you can see. Sorry. So over here, we have this graph that kind of summarize in short what we observe in the three regions when it comes to uptake of OPV vaccine within 24 hours and also uptake of BCG vaccine within 24 hours. So here we have like three measures. We have the baseline, which is navy blue. We have the midline, and then we have like the end line. So we collected data at three different points prior to the start of the study, at midpoint, and also at endpoint. And then we measured the percentage change in coverage across three the distinct settings. So what we can see here is that overall there was a dramatic improvement in the uptake of both vaccines within 24 hours. I think in roughly two-thirds of the facilities there was an overall uptake of improvement, a dramatic improvement. And then down here we see the proportion of children visiting the EPI service, the visiting the EPI unit who received OPV within 24 hours, because not basically all facilities offer immunization services. There are some health facilities that conduct deliveries, but at the same time do not offer immunization services. So when children are born, they have to like refer those children to facilities that offer immunization services. And this is really what this graph depicts. So most of these children, they actually come from facilities that do not offer immunization services. So facilities that essentially provide maternity services but not vaccination services. So you could also see an improvement in the number of and the proportion of children receiving these vaccines within 24 hours. And then over here you have challenges experienced by healthcare workers and so on. And the interesting thing is that when we started the study, we kind of sampled the perspective of healthcare workers and the healthcare workers and also the mothers to find out whether administering these vaccines within 24 hours is going to present a challenge, be it to the healthcare workers and also to the to the mothers. And interestingly, initially prior to the start of the study, a lot of people thought that it's gonna be challenging, be it the mothers and the healthcare givers. But after the study, at the end of the study, the end-line assessment did indicate that many of them actually, a sizable number of them did consider that it's feasible, it's practical, and it's easy to get children vaccinated within the first 24 hours after birth. So here there were a number of important lessons that we learned, particularly from qualitative interviews with healthcare workers, and most of these centered around three things: galvanization, sensitization of caregivers, and vaccine accessibilities. And here you could see some of the verbatims that the different people whom we spoke to said. 11 seconds. And then there were also a number of issues or challenges that were observed. One was essentially related to an increased workload because the maternity staff, in addition to conducting deliveries, filling pathograms, they also have to reconstitute vaccines, pick vaccines, reconstitute them, administer them, and then document. And that actually improved and increased their workload. And then there was also this issue of stock out and wastage rate, which was essentially high, particularly in facilities that where delivery rates were low, and then collaboration between the EPI and the maternity staff seemed to be a little bit challenging because normally this is something that is not being done. So establishing that platform for collaboration became very difficult, and most of the time the EPI staff actually they actually thought that maternity staff are wanting to take away their roles and responsibilities. And that is it. Thank you for your kind attention.
So my tech people, are we ready to go? Just
Can you hear me? Yeah.
Yeah.
Dr. Salisu is in the middle of a 2-day transit and he won't make it on time. But from the Turkish Air headquarters, where he was laid over, he made a recording for us. And I want to prepare you that the sound is not great. So I think we're going to try to start the recording. And Pat, I think you make a call. If it's really not working with the sound, then we can stop. But let's see how it goes.
I'll look to the audience. You guys tell me thumbs up, thumbs down, and we'll cut it. Fingers crossed. Here we go. Yeah. Innovation.
Before that, let's look at integration. From the WHO definition, we'll see that integration is about managing, delivering, and coordinating health services to provide continuum care that address needs of clients throughout life course. Integration is used in different ways, and WHO has outlined 6 most common usages that include provision of package of health interventions, setting multi-purpose service delivery points, provision of care over time, integration and referral of services, integration of policy, planning and management, and working across sectors. Integration has benefits that include increasing coverage, improvement in system efficiency, improved user satisfaction, and increase in demand for services. It also has potential risks that include negative impact on coverage, reduction in quality of care, providers refusing to accept additional responsibility, and beneficiaries not accepting the integrated services. To explore this, in 2020, Clinton Health Access Initiative conducted an assessment to identify opportunities of improving efficiency of service delivery, looking mainly at integration and flow of HC sessions. The findings include the fact that health facilities are indeed integrating services, but this is born out of convenience of the service providers, not to improve efficiency or based on any guidance. Secondly, the approach to service delivery was based on location and the beneficiaries of the service. Therefore, you will have different approach in different facilities. Thirdly, on planning for PHC services at the facility, it differs in terms of its approach, planning cycle, and scheduling the day of service provision. The schedule mainly depends on staff strength in the facility, clients turnout, seasonal changes, among other factors. Interestingly, these services require and utilize the same resources for service delivery planning, which implies inefficient utilization of resources. We've also explored barriers to service delivery, and clients cited especially waiting time as a major barrier to accessing services. 32% of clients interviewed cited this. Other barriers include multiple visits to health facility, distance from health facility, and the cost of transport to the facility, among other barriers. These findings are in line with several other findings that have been cited in other literatures. So based on these findings, models were developed and were field tested to determine their efficiency or their impact on efficiency on service delivery. So these are the models. They are not new, but they are developed around the provider of the service, the location of the service, and the time of providing the service. The provider-based model looked at provision of multiple services by the same provider. This fits a situation where we have single provider managing PHC. The information we have lots of these facilities in low and middle income countries. The second model, which is the point of care based model, mimics our health facilities and our outreaches because it's based on rotation of service delivery and multiple services are provided by different service providers. The third model is based on convenience schedule between provider and clients. So implementation of these models depend on the skills of the provider and the need of the clients. So the pilot of the models was assessed based on some indicators that were categorized as input indicators, process indicators, outcome indicators. The findings include the fact that health facilities had to update their microplan to reflect the need of the models that was implemented therein. We also find out that the average number of stages that clients follow from arriving at facility to accessing complete care is 6. These stages include, for example, the stage of triage, registration of client, consultation by provider, laboratory investigation, collection of drugs, etc. This average was a reduction from 10 stages in the assessment that was conducted earlier. Also, the average waiting time for provider model was much lower compared to care model that was twice. Also, both clients and providers have appreciable satisfaction across all the models, with provider-based models having the highest satisfaction across both clients and providers. This slide outlines some lessons learned that will be useful for adaptation and scale-up of the models. Thank you. This segment of the session will look at how integration improves uptake of services, specifically how integration of immunization with maternity services improve timeliness and coverage of birth cases. In Nigeria, vaccination coverage is poor, with national DPT3 coverage of 57% based on multiple indicator clusters of 2021. As we can see also, there are inequities in terms of coverage at subnational level, with some states achieving higher coverage than others. The national immunization schedule has 3 birth doses, BCG, OPV 0, and Hep B. Among the birth doses, Hep B has the lowest coverage. The recommended time for administration of Hep B to newborns is within 24 hours after birth, or at most within 2 weeks from delivery. This also limited the potential of improving coverage of this process, but it also presents an opportunity of integration of this vital service with maternity service in 2 states, which is in Sarawa and Kano. 4 steps were followed within this study. First is conduct of baseline assessment to determine the average date of administration of birth doses in selected health facilities. Data abstraction of records in maternity and immunization units was used to find this average. The second step involved using human-centered design approach to come up with strategies that were to be adopted. Different strategies were determined, which we'll discuss in subsequent slides. The third stage involved implementation of the strategies that had been determined over a period of 3 months. And finally, inline survey was conducted to assess the impact of the strategies. These are some of the strategies that were adopted by the facilities. First is delaying discharge of mothers after delivery. The facilities that adopted this doesn't discharge the mother after delivery until the child or the newborn receive the birth doses. The second strategy adopted by some other facilities is referral of newborns to immunization unit. The third one is some facilities that have opted to train the maternity unit staff to administer the birth doses within the unit to the newborns. And the last one here is that some facilities have created a stand within the maternity unit for administration of birth doses by RI unit staff. It's good to know that resources that are required for implementation of these strategies were made available. For example, in the last scenario where a stand was created, for example, we need a geostyle, for example, that will be needed for the storage of vaccines. At the end of the implementation, facilities that adopted delayed discharge of mothers They were able to achieve the result of vaccinating newborns within 24 hours after birth. This is from an average of 2 days at the baseline. For facilities that opted to refer newborns, they were able to vaccinate newborns within 24 to 48 hours from a baseline of 7 days, while facilities that train mothers would rather maternity unit staff to vaccinate the newborns they were able to achieve vaccinating those newborns within an average of 48 hours from a baseline of 9 days. Facilities that created a rise time were able to vaccinate newborns within an average of 5 days after delivery. Across all the strategies in both Nasarawa and Kano, we've seen remarkable improvement in proportion of newborns receiving the birth dose timely. At the baseline, only 17% and 26% of newborns received timely Hep B in less than 24 hours in Kano and Nasarawa respectively. After the intervention, this has increased to 73% and 67% respectively. For newborns receiving the vaccine up to 2 weeks after birth, the proportion has improved 95% from 64% in Kano and from 75% to 97% in Nasarawa state. Recommendations for follow and improvement of birth dose vaccines coverage include strengthening postnatal care policies to include provision of birth dose vaccines. This would include compliance with a recommended discharge time of 24 to 48 hours. The policies should also allow task sharing for birth dose vaccines to be administered by maternity unit staff. Data tools need to be updated with options of recording vaccines administered within the unit. There should also be capacity building sessions for maternity unit staff to administer birth dose vaccines, and the maternal and newborn child health guidelines and training modules should be updated with a module on birth dose administration. Vaccine storage devices should be deployed to maternity units to enhance vaccine availability and potency to drive dose vaccination in those units. Thank you very much for listening, and thank you very much for your time.
So I'm going to video the applause and send it to Tijjani.
Definitely want to applaud the effort to share those insights. Apologize about the audio quality, but appreciate your patience with that. There's one more special guest we want to invite in to speak. Faloke, if you are ready to share some insights from your learning on service integration delivery, you can take this microphone. Thank you.
Well, thank you very much, and hello, everyone. I want to really applaud our last speaker for the efforts to get that presentation. I think we should give him another round of applause. Really, that's massive. So I'm just going to provide a few reflections on the topic, looking at integration, primary healthcare, and where we are, the intersections where immunization and primary healthcare are mutually reinforcing and benefiting each other. So I'm Falake Olainka. I'm the immunization lead at USID based in Washington, D.C. And I just want to contribute a little bit to this discourse. One of the things, or a key set of the things that came out in the presentation that I would love everyone's feedback, are really looking at the framework for making this work. When you talk about birth dose, you talk about maternal vaccinations, you're really looking at a life course vaccination and integration with primary healthcare. But what is the framework that we need to be working with? Obviously, the issues around having a policy, national policy and national framework is really critical. And I'd love to hear your experiences as well. If this does not exist, it becomes very difficult at subnational levels to actually make this primary healthcare or integration with other stakeholders viable. So that's one. The other aspect is the leadership and the management. So you really shared some excellent data and analytics that are showing this. But the leadership and the management need to be able to come together in terms of the workflow for the midwives and the OBGYNs that are working with pregnant women and the deliveries. If they don't have access to the vaccines, it becomes, again, one of the big challenges that we need to overcome. How do we make the leadership and the management level to really see this as a seamless end-to-end approach, and how to bring the different units together? So you've got the midwives, the maternal health people, you've got the immunization people, and I've got to say that immunization has for the longest time been seen as a vertical program. How do we change that? If we're really going to make this work in the new era. So when you move from the management and leadership, we talk about the operational issues. And this is where the issue of human resources for health. Do you have enough? Is their scope of work being updated? Is there task shifting? You talk about the commodities that are needed, of course, on the vaccination end, but are we only concerned about the vaccination end? Are we not concerned about all the interventions that needs to happen for that newborn? How do we make that happen as a collective effort leading across? The other dimension that I would bring to this would be the measurements and the indicators. If there are no indicators that are being tracked or that are helping us to measure, we really don't know sufficiently the progress that we're making. It was nice to see the data that were shared. Those are important starting points. But there are other indicators in between that perhaps we can think about that help us look at the effectiveness of what that integration around service delivery and primary healthcare, how that is actually working. I will end on this note. The Immunization Agenda 2030, which you're all here, that leave no one behind, the strategic priority area 1, which is focused on immunization programs for primary health care and universal health coverage, has actually developed a framework for action of immunization and primary health care. And this is building off the WHO UNICEF theory of change for primary health care, looking at the 4 strategic levers, and then you've got the 10 operational levers. And so if you haven't had a chance to take a look at this framework, it's on the IA 2030 website. You can go right there, and here you'll be able to look at the different intersections and the examples of the linkages between immunization and primary healthcare. And there are also a number of really excellent case studies that are there. So there's a lot to build on. This is the direction that many countries, many countries are moving. And when we think about person-centered care, we think about human-centered design. And when we put people at the center, we find that the focus is trying to get as many services as possible available in high quality for children, the communities that they live in, and particularly when we talk about reaching zero-dose communities, we want to make sure that a package of services is available, including immunization, either as an entry point or as mutually part of primary health care. I think this is really, really essential. I said that was my last point. Actually, there's one more. So one of the things that I will just highlight is that USAID, we actually have a number of projects and investments that we've made in trying to look at the evidence in how to make immunization within primary healthcare work and to be effective. One of these studies is through one of our projects called Momentum Country and Global Leadership. And I'll be able to share that study after. There are a number of case studies. So here again, we have looked at the different enablers, and the enablers are really, really sitting within leadership, management, and looking at the human resources for health. Looking at these three are some of the most critical aspects of really ensuring that we can have effective integration, immunization within primary healthcare, immunization within life course, and ensuring that we're able to work across the different stakeholders. So you got to give those vaccines to the midwives, right? And this is a message that people, immunization programs need to hear more and more and more. Or you've got to be able to provide vaccination services within the postnatal uh, wards. A message they have to hear more and more. And most importantly, the country needs to have a framework and policies that can really support this direction. So with that, let me stop and I will hand the mic back. Thank you very much.
Thank you. So we have about 5 minutes left. Any questions for our two live 3D guests, please? Thank you for making the walk up here.
It's too cold, sir. Your experience. Oh, great. Thank you, Eric Laurent. I'm UNICEF headquarter and working on the national immunization strategy. And I would really like to jump on what Folake was saying. To me, for years we were speaking about integration, but first to me, this is the first calculations. I mean, volume of work, volume of people. Do we mean, let's say, more work for existing people, or do we mean two service with already people that we are combining? So let's make sure we are not making things wrong in the mathematics, because if so, we all know that we are going to be hugely challenged. And in that regard, what we realize every time we speak about the integrations, we are immediately touching human resources development. Okay, so what I really think we have to do in the country is to look into what's going on. It's not only immunizations, that's all the health services. Just a quick note on, and we will have time, I'm sure, during the weeks to discuss, in the national immunization strategy that we have been all together, and Folake is part of the steering committee, trying to promote in the last couple of years. We know that integration is one of the most challengeful points, like gender this morning, to write into the strategy. Because we may be advising and recommending integrations, but it's really a systemic issue and it's not so simple. We know that we will have to look into what's going on inside the national health sector. So let's just, I will stop here. Let's just think really volume of work, what it means, incentivizing also for changing. And the second one, how we properly frame, let's say, in the strategy and in the objective. Thank you.
Great, thank you for that comment. Mr. McCarney, I'm going to make everybody walk today. Yeah.
Hi, my name's Steve McCarney. I'm a consultant mostly with the PQS in this group. My question has to do with what changes you had to make, if any, to get the 24/7 service at the facilities. Were these staffing changes, task changes? Did someone have to get the key from the EPI guy? Were there structural changes? Did you have to have infrastructure changes that would make a difference? Thank you.
I think I can use this one. Thank you very much for that question, and really interesting insights from Folake and our colleague from UNICEF. So coming back to your question, I think we did a number of things. The first thing is that we targeted maternity services, and in our setting, maternity services are supposed to run 24/7, right? So the healthcare workers are there waiting for the pregnant women and so on. So that was like the low-hanging fruit. So the second thing was developing the workflows and then building the capacity of those the healthcare workers, the midwives who are there delivering women, that in addition to maybe administering oxytocin to the woman when she puts to bed, also think about the safe the safe bed checklist for the newborn. And one of the things that we did introduce in the safe bed list for the target facilities was the administration of the bed dose of hepatitis B, because already on that list you have in our own setting you have some certain things that we have to do, like giving an injection of vitamin K, cleaning what is it called again, the umbilical cord and suctions and so on. So that checklist exists. So the only thing we integrated was administering the bed dose of hepatitis B. But then we also needed to figure out where the vaccine will come from. And that was really where the challenge is, because in some facilities you have the EPI service next door, right? But in others, in other facilities, the maternity is like I don't know, maybe 300 meters away. The EPI service is somewhere, and in some other setting, the maternity is down somewhere, and vaccines are stocked in the district. So we explored all of these models, and we developed models that will be operationally feasible and practical for each facility. So for facilities without and immunization services, or facilities that will need to get vaccines from the district, we made arrangements with the district health officers to transport the vaccines in vaccine carriers to the health facility, particularly during the week, in the evenings and also in the night. But during the day, I think there was just this communication line that was set up between the different structures. So if a child is born at this particular time, please make sure you bring vaccines within 24 hours and so on. So there were a lot of different scenarios that we explored and we implemented. So I don't know whether that answers your question, but additionally, we had to print data collection tools, right, that we had to position in the maternity, and then figure out a system of having that data integrated into the API data collection system. But if we want to take this to scale, then it will actually mean that we would definitely need things like policy, as we were talking about, defining norms for the registers, defining indicators that should be integrated into the district health information system, and also pathways for transmitting and managing that data. So a lot of things will need to be done to make it happen. But the good thing is that I think the bed dose of hepatitis B is one of the vaccines that Gavi is considering to support countries introduce. And generally we know that Gavi will always issue, in short, for eligible countries, provided with some sort of a new vaccine introductory grant that will enable them to put in place all of these things. But again, it's important that countries are aware that these are the things, these are the systems or structures you need to put in place, and these things should actually go into the application, should be checked by Gavi before the application is approved. Otherwise, a lot of countries will struggle delivering the bed dose within the required time. So if you permit, I just had a couple of comments, particularly with regards to.
If you could give us, maybe a final comment and insight. We're at time. Thank you.
Okay, I think the first thing is looking at the state of things. How do we find synergies with different structures? Because the EPI program is well structured. It has been one of the oldest programs, be it in the health sector or in other development sectors. But we know we have about 17 the Sustainable Development Goals. Health is one of them. We also have infrastructure, which is one of them. So health facilities are part of infrastructure. And then we also have issues related to decent workplaces, decent work, and so on, which actually relates to human resources. So how do we find synergies with the actors who are involved in driving those other goals? So I think for me, that is really where the difference can come. If we want to specifically target the health sector, then we are going to be limited, because the Ministry of Public Health do not control the budget. They don't control investments and so on. So other partners do. So how do we bring them on board? How do we bring them on board to drive a common agenda of leaving no one behind? So that is really a question to the global audience, CDC, and those of you who happen to sit in the global panel for, is it the United Nations General Assembly? I think these are some of the things that you need to explore at the global level. How do you make these things happen? at the macro level, develop those frameworks, and then get WHO, UNICEF, or organizations like CHI to get this integrated into national and subnational plans.
Great, thank you for that. Quick round of applause for the speakers. Thank you. Thank you for joining this session, and I hope you get a chance to warm up soon. Thank you.